A very good afternoon to one and all. At the onset, I'd like to thank Manavi Madam and Team Pondicherry Aravind for organizing this wonderful event and for this opportunity. So, to begin with, endophthalmitis, as we all know, refers to inflammation of the eye's inner layers arising from colonization of infectious agents within the eye, leading to exudation of fluids into the aqueous and vitreous. So, it can be exogenous, as in surgical or traumatic, where the source is from outside, or endogenous, as in from other infections spreading to the eye from other parts of the body. So symptoms, mainly they present with pain, redness, blurred vision, and floaters. Common signs include poor visual acuity, corneal edema, hypopyon, vitreous inflammation, and poor fundus visualization. So what's a masquerade? So masquerade is a party or dance where people wear masks or other disguises, making you hiding who you are and making you look like someone else. So what are the masquerades in end of? They are a whole set of diseases. This talk is not exhaustive. So I'm going to touch upon only the more common ones. So we can classify it into three different classes. One, non-infectious inflammatory conditions, other infectious agents other than bacteria and fungus, or neoplastic conditions. So non-infectious inflammatory conditions we commonly come across are HLA-B27 associated uveitis, Behçet's, sarcoids, or other iatrogenic causes. HLA-B27 associated uveitis can present with sacroiliitis, peripheral arthritis, aphthous stomatitis, psoriatic nail or skin changes, gastrointestinal disturbances, urethritis, aortic insufficiency, and are associated with conditions like psoriasis, Reiter syndrome, inflammatory bowel diseases, seronegative arthropathies, psoriatic arthropathy, or ankylosing spondylitis, which is more common, Whipple's disease. So some of the things to remember when taking the history for this HLA-beta disease, the back pain which is there is commonly seen in 60 to 80%, and it is worse in the morning. It improves with exercise and as the day passes. It's insidious, chronic, and non-dermatomal. Peripheral joint disease tends to be pauciarticular, asymmetric, and peripheral, often causing swelling of an entire digit. Uveitis in this case is usually unilateral, acute onset, and more commonly anterior uveitis. You can present with hypopyon and confused with endogenous end of at times, but posterior segment is not much involved. Treatment more topical and steroid drops and mediatrics help in these cases. Sometimes periocular steroid injections are also needed. Behçet is another disease which can mimic an endophthalmitis picture, more common in the Japanese race and Eastern Mediterranean. Recurrent aphthous or genital ulcers are commonly seen, skin lesions, arthritis, epidermitis, vascular disease, and CNS symptoms. So in uveitis, in the Behçet's disease is more likely to be of longer duration, and it is more commonly bilateral and have more involvement of the posterior segment, and they have a poorer visual prognosis compared to the HLA-B27 types. The hypopyon may be mobile, forming and disappearing rapidly. Arthropathy is similar to HLA-B27, but 98% of them will have the history of ulceration, oral or genital. So that history is important. So other causes like sarcoidosis, this is one of the cases which was taken from literature, but it can also present bilateral, and it can have multiple snowballs in the vitreous, which can resemble fungal or viral endophthalmitis. So that is one thing you have to keep in mind. They more commonly may present with these candle wax drippings along the vessels, but sometimes they can mimic the string of pearls appearance also of fungal endophthalmitis. So other iatrogenic causes in medical agents, in drugs, the drugs which is notoriously connected with hypopyon uveitis is rifabutin. Or you should also ask a history of traditional eye medicine usage, all these saps of juices of plants which are sometimes instilled as part of native medicine. They can cause hypopyon keratitis and can mimic endophthalmitis. Other drugs like cidofovir, pamidronate, sulfonamides are all known to cause anti-uveitis, but hypopyon is usually rare in those cases. Surgical causes, lens-associated uveitis, post-trauma or surgery, retained surgical products post-surgeries, HPMC, thrombin, silicone oil, endotoxin mediated, and post even lasers hypopyon uveitis have been noted, like post-YAG-PA or post-panretinal photocoagulation. So TAS was already presented. So TAS is another differential diagnosis, or which can masquerade like an endophthalmitis, but usually it presents in a very early stage, 12 to 48 hours, limited mostly to the anterior segment. Diffuse corneal edema, IOP may or may not be elevated, improves with topical or systemic steroids. So again, lens injuries is again one thing which can mimic endorphs. So in cases which are presenting post-complicated surgeries, you have to think also about cortex or which is in the vitreous and inciting inflammation in the eye. So this is one case which was like post VR surgery, developed a hypopyon uveitis and was later found to be due to a post PC rupture during the surgery, and it resolved with surgical management. So sometimes we get all these endorphs with the injections, intraocular injections. You should also know that sterile endorphs can also happen post intraocular injections, more commonly with triamcinolone or astronite. It can be of two variants, one sterile endophthalmitis variant and one pseudo endophthalmitis. Sterile endophthalmitis occurs in 0.2 to 6% of cases. This occurs within 3 days. In all these sterile endorphs, mostly there is no pain for the patient, but you will have anterior chamber hypopine can be present more commonly in the pseudo endophthalmitis, where it's the actual drug which is coming into the anterior segment because of either weak sonules or some other way where the drug comes anteriorly. Whereas steroid endorph is more due to some endotoxins or drug preservatives along with the drug. So anti-VEGF also can cause sterile endophthalmitis. As per literature, 0.09 to 1% of injections can have this, and it presents very early within 48 hours. So we had a recently referred case of PST from a surgeon who, while giving PST, the patient moved their eyes and the drug entered inside the eye, and it presented with the hypopine uveitis sort of picture with the AC having the drug, and we surgically operated. So other infectious agents, Toxocara, syphilis, Toxoplasma citicercosis, Hansen's, brucellosis, HSV infection. And in our country, we should not forget tuberculosis also. That rarely, if there is a disseminated tuberculosis or uh, in a patient with HIV, that can also rarely cause hypopine end of sort of picture. Toxocara causes endophthalmic form of ocular toxo, layered hypopyon, history of pica or contact with puppies. Serological investigations may not be helpful in Toxocara. They usually respond to topical steroid, but concurrent posterior segment inflammation can require management. It's mostly clinically, you have to diagnosis clinically. You see the peripheral granuloma with band from disc to the granuloma. Syphilis is again with the systemic features. You have to keep this a great masquerader. You can have posterior segment involvement in this also, and it's a treatable cause. And you have to keep in mind, treponemal test is better compared to VDRL or RPR, where disease activity becomes native over time. So toxoplasma is another condition where you have a vitritis with fog in light in fog appearance. Cysticercosis, when the cyst is broken, it can cause dense vitritis. Otherwise, the vitreous is usually very clear. So this is one case we recently operated with dense vitritis. It was found to be a ruptured cyst. So usually prognosis is poor in these cases. Hansen's disease, this is a publication by Ratna Madam. Leprae basically was found in the hypopyon. So you can have neoplastic conditions like leukemias, AML, ALL, AML and CML usually can present with this. A blood-streaked hypopyon should raise your suspicion. Local or they can temporarily respond to steroid therapy, but AC tab can confirm your diagnosis in case of strong clinical suspicion. So leukemias in the extreme age groups, you have to keep this in mind. Frequent and severe infective episodes, non-acute onset lymphadenopathy. Blood counts are the basic investigation to be done in this case, along with AC and diagnostic vitrectomy. Again, in lymphomas also can present with hypopyon uveitis, and these should be kept in mind. You should investigate with full blood count and flow cytometry where possible. Diagnostic vitrectomy can be helpful. They can also masquerade like a fungal endoph or subretinal abscess. Again, subretinal sampling in these cases can give a clue. So retinoblastoma in the young patients below 5 years, you have to keep this in mind. A good ultrasound can most of the time diagnose a mass with calcification for you, even in case of a hypopyon. So other metastatic tumors are very rare, but these also should be kept, especially in the extreme of ages. and with systemic complaints. So black hypopyon has been described with melanoma, but again, this is a very rare condition. So last but not the least, corneal disorder should be kept in mind, and these can also present with hypopyon uveitis, microbial keratitis, or non-infectious corneal injury like chemical injury, alkali injury, thermal burns. All these can also cause a end-of-like picture. So take-home message: before you think about all the masquerades, the most important DD for a masquerade of end-of is endophthalmitis itself. So that, because that is very serious and you have to tackle it at once. History and clinical picture, systemic and ocular offer valuable clues. Appropriate investigations, imaging, serology, tissue samples, etc. should be advised as per the case. Non-response to standard of care for end of, you have to again think about these masquerade syndromes. Thank you.